MBBS Medical College, immediate past General Secretary of IPS. He is editor of Journal of Psychosexual Health, President-elect South Asian Societies for Sexual Medicine, affiliated to International Society of Sexual Medicine, formerly President of Indian Association of Geriatric Mental Health, formerly editor of Indian Journal of Psychiatry from 2004 and then 2007 to 18, co-chair of Psychiatry and Human Sexuality section in WPA, President-elect SASSM, affiliated to ISSM, publications and review papers 346, books and book chapters 26. He has received Marfati and DLN Murthy Rao Oration Awards, President of Karnataka Sexual Sciences Academy. The next chairperson is Dr. Neena Sawant. She is from Mumbai, currently professor at KEM Hospital, consultant psychiatrist at Global Hospital. More than 28 years of experience. Areas of interest are sexual medicine, child psychiatry, and neuropsychiatry. Has authored 5 books on problems in children and parenting in vernacular languages for general public. Has more than 95 national, international publications, 100 publications in magazines. Vice President, IPS West Zone Branch. Advisor, IPS West Zone Branch, PG Psychiatry Education. Chair, IPS Sexual Medicine, Medicine Specialty Section. So now the session is over to you, both the chairpersons.
Dr. Rao, would you introduce the topic? Dr. Rao is not there, Dr. Ali?
Dr. Rao is there. He is there.
Good evening, all. In fact, I'm at extremely happy that this particular topic, that to my very close friend, Dr. Adarsh Tripathi, is presenting. This topic, sexual issues and psychiatric disorders, is very well known to everybody. We have a range of drugs available which are used for the treatment. The side effects may be, but all said and done, when you are treating psychiatric disorders in general, invariably the whole range of effects we can expect. There are some therapeutic, there are some side effects related issues. And ultimately, when we try to look at depression as one of the very specific disorder, we are all well aware, often it is missed, even the treatment of it. When you are treating with some of the antidepressants, people improve and their sexual functioning also improves. There are quite a few people land up with difficulty because depression improves, but sexual problem appears. So this is one of the very funny situation. And unless the therapist is well aware of what type of drug to choose, in whom and in what context, unfortunately, we'll be doing a lot of misery. In fact, we'll be bringing a lot of misery to the couple. So this is one of the very important first step point we should remember. I just like to bring to the focus another aspect, this WPA classification of sexual dysfunctions. Here, the axis 1 contains the specific sexual problem for which individual is seeking help. The second axis 1B is called as concurrent comorbid condition. Either it could be physical and psychological. And among them, depression is considered as one of the most important thing. When somebody is not responding or some problem is created in the management, do keep it in mind, depression. So that what actually we are trying to look at is actually multiple nuances are there. And we have one of the best person to answer that particular area, clear the doubts and makes it topic simple. Dr. Adarsh Tripathi is there. Anyway, we'll be taking the questions and a lot of discussion at the end of it. I request Dr. Neena Sawant to introduce Dr. Adarsh Tripathi and to proceed. Thank you.
Yeah, thank you, sir. Good evening, everybody, and my regards to all. Thank you, Thursday Musings organizing team, for giving me today's opportunity. Well, yes, as Dr. Rao said, it is an extremely essential topic and something which is very, very much needed in our day-to-day clinical practice. Because as psychiatrists, yes, we do have the proficiency to detect, ask for sexual dysfunctions, but somewhere there is a lassitude due to which we're just not interested, or probably we don't venture out to ask for these sexual complaints, whether it is in patients of depression, whether it is in patients who've been started on antidepressants, and we do know that they can cause sexual dysfunctions. But till our patients complain, we don't ask. And sometimes I feel that is the biggest root of the problem. Well, it gives me great pleasure to introduce Dr. Adarsh Tripathi, with whom I have conducted several workshops in the past. And I would like to reiterate that, yes, he is the most ideal speaker for today's session. He's professor at KGMC Lucknow. He has, to his credit, more than 130 national and international publications. He has edited 3 books, has received several awards, and has a wide interest in the fields of cognition, cognitive neurosciences, CBT, spirituality, apart from human sexuality. I'm sure we're going to have a fascinating session on how to approach and manage treatment emergent sexual dysfunctions, which are caused by antidepressants. So without wasting much time, over to you, Dr. Adarsh.
I just forgot to mention one point. Anybody conducting 145 programs continuously without break, only very potent individual only can do that.
Thank you, sir.
Thank you very
Yes.
much for this talk.
Thank you very much, chairpersons. And obviously, there is no doubt on potency of organizers. Thank you very much, Nina ma'am, for the kind introduction. And thank you very much, organizers, for inviting me to this prestigious forum. I am very much thankful that is my slides visible now?
Yes,
Yes.
yes, yes.
Full screen, you can go.
So I'm very much thankful that my chairpersons are very learned people in the field of sexual medicine. So I hope they'll be able to assist me in the question answer sessions. So when we talk about treatment emergent sexual dysfunction, this is the day-to-day challenge which we face in our clinical practice. Almost every day, we see cases where we have initiated treatment and the patient is complaining of some difficulty and dysfunction in sexual functioning. And quite often, this is very tricky situation to handle. There are some broad guidelines and suggestions, but most often those broad guidelines and suggestions are not helpful for a lot of individuals. And in most of the cases, we had to take a very nuanced approach in handling the sexual dysfunction which has emerged during treatment. So, which will be discussing that what is that nuanced approach for individual patient that can be undertaken during the treatment. For the initial few minutes, I'll be going through, rather flipping through some of the important concepts in sexual functioning in health and diseases, just to keep us in the same page that whether sexual dysfunction has emerged due to any cause, including the psychotropic medication, but few of the basic things that we always have to keep in mind whenever we are handling with sexual dysfunction of an individual. We all are very familiar with this biopsychosocial model of etiological attributions of psychiatric disorders. In the sexual disease also, there are biological factors. Obviously, you can see that many of them are listed on the screen. A lot of psychological factors that do impact sexual disorders, its manifestation and the way it is presented and the way the treatment are sought or accepted. There are definitely important social contributors that influence sexual disorders. In addition to all these biopsychosocial factors, there is also another important dimension that need to be kept in consideration while handling patients with sexual dysfunction. That is a relational aspect. This relational aspect is not only important in understanding etiology of sexual dysfunction, it is also very important in handling, assessing, and managing the case of sexual dysfunction. So these relational aspects might include the quality of interpersonal relationships, both sexual and non-sexual relationship, marital discord, mutual trust, partner's health or sexual problem, or desired discrepancies, to name few of the important relationship issues. while we are listing the long list of etiological factors that can contribute to development of sexual problems, we also need to keep in mind that in one individual, several factors might be contributing in the causation of sexual dysfunction. And those several factors might influence the trajectory of sexual dysfunction in various ways. Like some of those factors might only act as a predisposing factors that may be constitutional or developmental factors. Some of those factors may be precipitating factor that has been present at the onset of this sexual dysfunction, which we are going to handle right now. With these precipitating factors, some of the factors may be helping in maintaining the problem. Many of the relationship factors do come up here, and some contextual factors that need to be taken into consideration while handling the cases of sexual dysfunction. Another general understanding that psychiatric disorder and sexual issue, as Dr. Professor Rao sir was mentioning earlier, they do have a very close correlation. And this correlation can be due to either having a direct influence, because having psychiatric disorder causing sexual issue, or sexual issue causing psychiatric disorder, or consequence of psychopathology or medication that we are using to treat psychiatric disorders. And there is another third very important theory that a lot of common causes might be influencing both these disorders. So I'll be elaborating this point a little bit in more detail, because in individual patient, those factors may be more important. So common etiological factors, some risk factors can be important for both sexual disorders as well as psychiatric disorders. Certain aspect of phenomenology, like in depression, if patient is having low self-esteem, is having low motivation, low interest in initiating or engaging in sexual activity, that might also contribute to sexual dysfunction, in addition to the sexual dysfunction that is being caused by medications we are using. Other comorbidities like anxiety disorder, like any other additional psychiatric comorbidity can also influence the onset of sexual dysfunction. Substance use are one of the important contributors that we need to keep in mind while handling individual case. Several interpersonal factors, personality related factors, living situations, those are the situations that need to be understood and taken into consideration while we are trying to handle the case. There is also another broad this paradigm about thinking that why sexual dysfunctions are very common and in what way they are influenced by psychiatric disorders, as well as treatment that are important in psychiatric disorder. So the important phases of sexual response cycle, like desire, excitement, and orgasm, they are influenced by neurotransmitters and hormones. So the positive effect in general, these are very broad understanding and conceptual things, but it is good to brush through them before we initiate the specific presentation. Like dopamine, melanocortin, testosterone, estrogen, they are having in general enhancing or positive effect on desire. Prolactin and serotonin have dampening or negative effect on desire. Nitric oxide, norepinephrine, melanocortin, acetylcholine, dopamine, testosterone, estrogen, they have in general facilitatory or positive effect on excitement, and serotonin have a negative effect. Orgasm is facilitated by presence of dopamine, norepinephrine, and nitric oxide, and it is inhibited by serotonin. So we can see that one of the most important treatment target of depression, like most of the treatment strategies in depression, increases the serotonin level in brain, and they in general have a negative or inhibitory effect on several phases of almost all the phases of sexual response cycle. That is why sexual dysfunctions are often very important in handling the case of a depression. If we talk in broadly about what is the epidemiological data saying about treatment emergent sexual dysfunction, the rates are somewhere between 50 to 70%. And if the patient is using SSRI, the rates are even higher. We know that patients themselves report a very lesser number of sexual dysfunctions. So spontaneous reporting of sexual dysfunctions is very less. And there is good amount of research data that says, even if you ask a single question that how is your sexual functioning on follow-up of patient of depression, the rate of reported sexual dysfunction goes very high. Why sexual functioning assessment and its handling is important in management of depression, that is potential risk of relapse and other negative repercussions. The most frequent symptoms that are reported by treatment emergents are reduction in sexual desire and delayed ejaculation, anorgasmia, lack of ejaculation, or other side effects, and these are usually least well tolerated, and specifically males are more bothered by these side effects and may be important causes of drug discontinuation and incomplete treatment. When we are talking about individualization of approaches, so I'll be talking about this when we were saying nuanced approach, we'll be talking about this thing in more detail, but just to put in perspective that why this individualization is important, I have just kept these three cases here. So in all these cases, the specific kind of strategies I'll be discussing will be utilized in a different manner. Like this case one is 48-year-old male, office executive, married in a stable relationship, is being treated for first episode of depression and currently using 20 milligram of citalopram and 0.5 milligram of clonazepam for the last 8 weeks. He has just started showing improvement on symptoms of depression, and on this visit, he is reporting loss of desire, significant delayed ejaculation. He is also having diabetes mellitus, hypertension, which is stable on medical management. The other case is a 36-year-old female who is housewife, married for 10 years, having 2 kids, being treated for first episode of depression and comorbid anxiety disorder, currently receiving paroxetine 37.5 milligram and etiozolam 0.5 milligram BD. And in current visits, he is reporting complete loss of desire and anorgasmia after starting treatment. Her depressive symptoms are completely resolved for at last 8 months. And the third case is a case of 26-year-old unmarried man that is not currently sexual active, but being treated for third episode of severe depression. He is also having positive family history of depression, currently receiving venlafaxine 225 milligram, lorazepam 2 milligram. He is having history of non-response to any other antidepressant earlier, responded only to venlafaxine. Several other medication trials has failed earlier. Currently, he is reporting that he is having erectile dysfunction and is very, very much concerned about sexual dysfunction and pushing the doctor to handle sexual dysfunction on priority right now. So these are 3 different situations where the strategies which we are going to discuss are going to be handled in different way. Although broad strategies are similar, but we will be handling those strategies in specific, unique way in all of these cases. That is why individualization is important. Sorry. How to go back in slides? So when we are talking about assessment, that when a person of depression has came to follow up, and we are either having suspicion of having sexual problems, or the patient is spontaneously reporting sexual dysfunction, what things that we need to have in consideration, that what is the current illness severity of the patient, what is the current level of functioning, both general functioning as well as area of sexual functioning, and the level of improvement that is being reported in depressive symptoms. In addition, the distress or importance of sexual side effect in individual cases is also very important. That is a very pertinent point, need to be understood, that in one case, distress due to sexual dysfunction is very high, where we need to handle it immediately, while in other case, the sexual dysfunction might be even severe, but distress is lesser, so we might wait for several weeks or months before handling sexual dysfunction. We also need to consider past episode, because in each of the strategy which we are going to discuss, there are some risk of relapses or potential possibilities of relapses in some of the strategies. So we need to think that what is the past episode level number, what their severity, what is the potential of relapse of this case, and what are the consequences of relapse if that happens, and whether the patient is willing and capable of handling that kind of relapse if that happens. That will determine what kind of strategy we are going to take in this particular patient. We also need to understand and assess the previous functioning of previous sexual functioning of the case. That is a very important thing, because a lot of time, as we have discussed earlier, these sexual dysfunctions are present before starting of psychiatric disorders. So baseline understanding is assessment is important. What is the current functioning as well as future sexual activity, like the case 3 which we have discussed. Although the person is very, very concerned, but his potential to engage in current or near future sexual activity is very less. So we need to handle that case in that unique way and need to counsel in that way. We also need to assess the physical status, because sexual symptoms or sexual dysfunctions are significantly affected by physical conditions of an individual, specifically the several common medical disorders like diabetes mellitus, hypertension, and other chronic diseases, and side effect of profile of any additional or alternative medications that we are going to use, and also the side effect of medications that person is using for other medical disorders. Like sometimes people are using antihypertensive medications for several other medical disorders that may also contribute to sexual dysfunctions people are reporting right now. Excuse me. So while as we have discussed in the previous slide, just to re-emphasize that when we are handling the sexual dysfunction, we also need to take into consideration in what level of improvement the person is currently. That whether the person is just recovering, he is in complete remission, or the person has completely recovered, and what are the possibilities of relapse and recurrences in treatment strategies that we are going to undertake. What are the aim of management of treatment emergent sexual dysfunction? The aim are to eliminate treatment emergent sexual dysfunction at least partially, because you will see that in all the cases it might not be possible to remove all the sexual dysfunction, or even the patient might not be willing to take the risk of doing a complete overhaul of the treatment at the risk of relapse. So we aim to reduce the treatment emergent sexual dysfunction to the best possible way without jeopardizing his psychiatric status. And to re-emphasize that none of the strategies mentioned is devoid of risk. So some carry risk of relapse and appearance of side effect related to new treatment, which we might offer for management of sexual dysfunction. So individualization in management of sexual dysfunction is important. This is sort of re-emphasis on important factor for assessment, but even at the risk of repeating, I would like to mention that assessment of current symptom pathology, duration of treatment, course of illness, risk of relapse, these are the important factors need to be assessed. Individual factors like cost of relapse, what is the current relationship status, whether the person is sexually active or inactive, what is the current weight, current blood sugar level, what are the trade-off the person is willing to take while doing management of sexual dysfunction, risk, benefit, risk ratio analysis. Then medication related factors like what is the type, dose, duration of use for this particular medication, and level of impairment due to sexual side effect and potential for treatment dropout if this sexual side effect is not handled here right now, and relevance of sexual functioning for patient that or person's partner, because in certain cases although patient might be reporting that they are having sexual dysfunction, but sexual functioning might not be very much relevant in their life as of now, currently or in long perspective also. So that will also have a repercussion on the way we are going to handle sexual side effects. Before specifying specific strategy, I'll also like to show this slide that have a large, this has a data collection from several important reviews. The percentage here are not very exact. There might be certain variations in reported side effect profile, sexual side effect profile in different studies. And also we might need to consider that this slide is made from sexual side effect reported in patients who are using these medications in drug trials. So because we know that some of the medications like bupropion or some medications that are later reported might enhance sexual functioning rather than dampening it. So we need to understand this data here of this slide in this context. So the biggest or most important offenders in sexual functioning are paroxetine, sertraline, fluoxetine, citalopram, and venlafaxine. Imipramine, duloxetine are somewhere lesser than that. Citalopram, fluoxamine in ranges of 30 to 40% of 50%. Venlafaxine is a molecule that has reasonably lesser sexual side effect with good efficacy profile in depression and other anxiety disorders. Bupropion and mirtazapine have very less sexual side effect and may be facilitatory in sexual functioning for a lot of patients. And the certain newer medications like vortioxetine, agomelatine, vilazodone have least sexual side effect. Even the reported sexual side effects are mostly in the ranges of placebo-controlled data. So possibly they have very, very less number of sexual side effects. There are large number of scales. I'm not going to talk about detail of these scales. I'm just showing them that there are certain specific and non-specific scales one can use to assess sexual functioning, at least initially to familiarize oneself that how to assess sexual functioning of patient being treated for depression. So important one are the first rating scale and the CSFQ sex effector scale are some of the important rating scales that can be utilized for this purpose. Now we are going to talk about the specific management strategies for handling sexual dysfunction that has emerged during treatment. So there are a lot of treatment strategies. We'll be going one by one. The first strategy that is reported in literature is waiting for spontaneous remission or adaptation of drug. I also like to mention that this is one of the most widely used method for handling sexual side effect of medications. However, we have a lot of doubt on its effectiveness. Improvement of TESD varies among patients from few days to few weeks and up to few months. As Dr. Rao sir mentioned earlier also that in a good number of patients, actually sexual functioning might improve with improvement of depressive symptoms. So in good number of patients, this strategy might be useful if the medication particularly is not causing sexual dysfunction in that particular person. But if the medication is implicated, that person is specifically having sexual dysfunction that has initiated after treatment, the data says that most patients do not present any improvement even after several months of treatment. So that this is one of the least useful strategy also for established treatment emergent sexual dysfunction. There is some data to show in this regard also that the good number of studies, some of them are mentioned in the slide, have shown that the recovery, partial or full recovery after several months is very less. That you can see that only less than 10% of patients do report spontaneous or remission of sexual side effect or adaptation to this side effect. So in general, we need to understand that adaptation to sexual side effect of SSRI do not happen. This is a broad consensus strategy. The second strategy is lowering the dose or withdrawing treatment. So we also must understand that in what kind of situations this strategy can be useful. There is wide individual variability in treatment emergent sexual dysfunction depending upon pharmacodynamic and genetic aspect. A good amount of data shows that reducing the dose of antidepressant to half improves TESD in 75% of cases. So if we are able to reduce the antidepressant dose by half, 2/3 of the patient report improvement in sexual dysfunction. And almost total recovery has been reported in most of the patient after few days or week of withdrawing of SSRI treatment. Some of you might be, I know that some of you might ask in the question that there is an entity reported as post SSRI sexual dysfunction, that certain amount of patient reports a continuing sexual dysfunction even after withdrawing treatment, but that is a debatable and controversial diagnostic entity. And most of the data shows that most of the patient recover from sexual functioning when medications are withdrawn. In this strategy, as we can all understand, that significant risk of relapse is present. So this strategy can be suitable for only in those patients where either the medication has been continued for significantly long period, where reduction of the doses is likely to have lesser chances of relapse, or when you are considering reducing the doses and even might stop the treatment if the patient has completely recovered. In this strategy, gradual reduction is helpful to prevent withdrawal symptom as well as risk of relapse, because when we are reducing the doses, if we are reducing it gradually, even the risk of relapse is reduced. Doses reduction in association with other non-serotonergic antidepressant is sometimes useful. Like sometimes if the doses are being reduced for purpose of having lesser sexual side effect, another medication can be given to support this dose reduction. We'll be discussing this strategy in more detail. The other next strategy is add-on treatment for handling sexual side effect. This produces dissimilar result regarding efficacy depending upon what kind of sexual side effect the person is having and what is their response to treatment based on the strategy. Different agent has been utilized for handling sexual side effect, and some of the important agents that are being used for this purpose are cyprohepatidine. We know that this act by 5-HT antagonism. The most common doses are used 4 to 8 milligram, given usually at the time of bed because these are sedating medication, and it is having potential to cause increase in appetite and weight gain. So we need to select the patient accordingly. Buspirone is another agent that can be useful for reduction in rates of sexual dysfunction. The usual doses are 15 milligram to 30 milligram for this purpose, and this can be a useful treatment adjuvant because this can have additional anti-anxiety effect on the person. So this can be useful treatment strategy in a good number of cases. Then bupropion is one of the very important adjuvant medication that is very commonly used also. It is dopaminergic and adrenergic facilitatory molecule, predominantly dopaminergic system. This reduces the risk of sexual side effect as well as have some facilitatory effect specifically on desire and in some cases erectile function. Mirtazapine can also be used for this effect as an add-on treatment. It is a good adjuvant medication because it gels very well with the SSRIs. It does not have synergistic side effect profile with mirtazapine with other SSRIs. However, it has independent side effect of sedation, weight gain, and potential to increase the cholesterol and blood sugar level alteration that need to be considered in case-to-case basis, that in what kind of cases we can use this strategy. Yohimbine is another potential molecule that is as of now available in India. It is alpha-2 adrenergic antagonism. However, there is no good amount of data available for efficacy of this strategy, though it is commonly used clinically to handle this case. And in my practical experience, it can be useful in certain number of cases. However, it is a costly molecule, so that we need to take in consideration before selecting for individual patient. Ginkgo biloba extract is a nutraceutical adjuvant for add-on treatment. There is heterogeneous data in general, and in clinical practice, it is also very difficult to report that whether Ginkgo biloba is effective or not, because often it is combined with several other treatment strategies, but it is a very commonly used mechanism that is used as add-on treatment. Among all these strategies which we have discussed earlier, bupropion is highest supported by evidence base because it has 3 RCTs, and as those RCTs have shown that it is an important adjuvant as potential agent. The caution with bupropion is that it might worsen anxiety in certain patients, so we might need to see that what kind of patient suitable or what other kind of adjustment that might be needed for that kind of person. Mirtazapine is having good effect in certain amount of patients. Specifically, what is done with the bupropion and mirtazapine, that if sexual side effects are significantly bothersome, we can plan to reduce the SSRI doses to half gradually and add these molecules. So in this combination, these molecules can have a reasonably good effect in reduction of treatment emergent sexual dysfunctions. Then PD5 inhibitors in general, we know that these are very useful molecule in general for sexual dysfunctions, erectile dysfunction, very well tolerated molecule. There is some suggestion that it have additional antidepressant properties also by blocking central anticholinergic receptors. There are certain limitations of use of PD5 inhibitors because they do not improve sexual desire or delay ejaculation per se. And for most of the molecule except tadalafil, this require previous planning of sexual activity. And if you are using tadalafil, that need to be given daily regime or every 3 days regime, depending upon the patient need and personal context. Another strategy that can be suitable for a very small number of clients, some of my clients who are maintained non-antidepressant for several years are using this strategy. And specifically the patient who are living out station and they visit their household, suppose once in 4 weeks or once in 3 months, 6 months, some of those patients are able to utilize this strategy effectively. That is short-term interruption of antidepressant or weekend holidays. So this involves withdrawing antidepressant 2 to 3 days prior to sexual intercourse and reintroducing it afterward. So this can be useful in patients where treatment cannot be stopped completely, but people are not having significant withdrawal symptom on missing 1 or 2 doses. Where primary sexual dysfunction is anorgasmia. In those cases, this strategy might be more useful because anorgasmia is shown to be directly related with blood level concentration of antidepressant. So if blood level concentration of that medication is reduced on that particular day, possibility of anorgasmia is lesser. And obviously this strategy cannot be utilized for fluoxetine because this have a very long half-life and this strategy will not be useful in that case. However, we need to understand that this have lack of adherence and discontinuation syndrome after sudden withdrawal in certain cases, so need to be understood in case-to-case basis. Lowering the doses to half 2 consecutive days in week prior to having sexual relationship may also be considered in certain number of cases, because theoretically, as we have discussed earlier, that reducing plasma level of antidepressant can improve erection or lubrication quality and does not However, it does not improve lack of sexual desire. So if desire dysfunction is predominant dysfunction during treatment emergent sexual dysfunction, this will not be a useful treatment strategy, because desire per se is impaired by a different pathway that take a few weeks to come back after stoppage of antidepressant or changing treatment strategy. There is some research data also available to support this strategy, however, not good amount of data. Then switching to non-serotonergic antidepressant. So rather than adding those medications which we discussed, person is switched from serotonergic to non-serotonergic medications. Precaution is required to prevent discontinuation syndrome, and obviously pathologies where SSRI is first treatment option, like in OCD and several other situations. This strategy might not be very useful. There is potential risk of destabilization, relapse, non-response, because we understand clinically that a lot of patients who are stabilized on one medication might not be easily, cannot be easily stabilized on second medication, specifically if the medication is non-serotonergic group medication. And client must understand that this is an experimental strategy. It may or may not work, and having risk of destabilization, relapse, non-response, as we discussed earlier. The switching strategies has been reported with bupropion that have treatment emergent sexual dysfunction in as placebo. We can use it in combination, and in compared to SSRI, it has much lesser orgasmic dysfunction, lesser arousal, and desire problems. Might not be very useful for anxiety disorder. Agomelatine has been theoretically promoted significantly for management of treatment emergent sexual dysfunction. But as a clinician, we know that this has not been very successful antidepressant molecule. So I personally do not use agomelatine as a switching strategy. However, I have utilized this strategy in reducing doses of SSRI and adding agomelatine from up to 25 milligram to 50 milligram. And I have found that this strategy can be useful in certain number of cases where I have been able to reduce the dose of primary antidepressant in patients who have been maintained on those antidepressant for at least several months, and they have been reasonably clinically stable on that molecule. So agomelatine might be useful for that kind of clinical situation. Mirtazapine, we have discussed earlier also, is a very useful molecule for set number of patients who can tolerate its side effect like weight gain and sedation. And research data shows that up to 70 to 90% of patients do report improvement in treatment emergent sexual dysfunction if they have been successfully switched to mirtazapine, that they are able to tolerate mirtazapine, and mirtazapine is being effective for their primary psychiatric condition also. Then switching to trazodone is also one of the theoretical report strategy that specifically if patient is using the older molecule like TCAs or SSRIs, but we know that trazodone has its own group of side effects, and in effective doses it might have might create difficulty in tolerating that side effect of sedation, and those sort of things might be difficult. However, this is a potential treatment strategy, specifically in cases where insomnia is very significant and patient can be held in, maintained on low doses of antidepressant, like up to 50 milligram of trazodone. If the patient can be handled on those kind of doses, it can be a potential treatment strategy in comparison to serotonergic medication. Desvenlafaxine is one of the molecules that has a good clinical efficacy in depression and anxiety disorders, and quite lesser number of side effects in comparison to several other antidepressants. It can improve sexual desire and orgasmic dysfunction if patient has been shifted from other serotonergic medication to desvenlafaxine. However, research data shows that sexual arousal is not particularly much affected. However, in my cases, in my experience, desvenlafaxine do causes relatively lesser amount of sexual side effect, specifically in patient where we can handle the patient on lower doses of desvenlafaxine, usually up to 50 to 100 milligram. Beyond this 100 milligram doses, desvenlafaxine also causes good amount of sexual dysfunction. And if we need to use high doses up to 200 milligram, the sexual dysfunction is almost similar to other serotonergic medications. Then vortioxetine is the new kid in the block, as we say, that this vortioxetine has a very promising result specifically for treatment emergent sexual dysfunction. We are using it for last several months now, and our confidence has increased in use of this medication. I would say that this is a very useful medication in management of depressive and anxiety disorder. Only bothersome symptom is GI side effect that may be very serious in certain number of patients, and up to 10 to 20% of patients have really bothersome GI symptom. But if the person is not having GI symptom, vortioxetine is reasonably effective molecule, and in context of sexual side effect, the sexual side effects are reasonably less, and I have encountered very less number of patients reporting sexual side effect who are using vortioxetine, even in higher doses. So this can be a useful potential strategy, and the improvement is been reported in all phases of desire, arousal, and orgasm if patient has been shifted from other SSRI to vortioxetine. Vilazodone is another treatment strategy that has been utilized for management of sexual dysfunction. However, per se, I have not used vilazodone much, but people who are using vilazodone, they say that this is a reasonably useful molecule, and theoretical data shows that it has similar rate of sexual dysfunction with placebo, so does not have much sexual side effect and can be a very useful treatment strategy for certain number of cases and have good evidence base too. In addition to medication treatment, which we have been discussing, psychoeducation obviously plays very important role in using the nuanced approach which we were discussing in comparison to individualization of the treatment. If you think about the three cases which we have discussed earlier, in all those three cases, we have to use the strategies in addition to a lot of psychoeducation, a lot of preparation, a lot of handling their questions, and a lot of saying that at what stage of treatment we are going to offer this kind of change in medication or another medication. So good amount of psychoeducation is useful, and physical exercise do have improving effect on sexual desire and satisfaction. So we all should, wherever possible, should always advise improve physical exercise, which can be helpful both for psychiatric disorder as well as sexual dysfunction. Some other strategies like taking short-acting drugs at times has lowest and taking at the time that have lowest level during sexual activities can be having lesser kind of sexual side effect, like using immediate paroxetine in the morning time. So it might have lesser level of lesser blood level, so might reduce sexual side effect. So person who is using control release paroxetine might be shifted to immediate release paroxetine for some time and see that if this strategy can be useful for that particular person. Taking medication after sexual activity or just before, so that this have lesser sexual side effect. Physical exercise, this is another point actually. Addition of testosterone cream or gel in men with low serum testosterone level, so it can be a potential add-on treatment. And testosterone patches, although not very freely used in India, availability issues are also there, but they can be useful for improving libido in specific cases of treatment emergent sexual dysfunction. In addition to the strategies which we discussed earlier, some cases may need other non-pharmacological management strategies for sexual dysfunction also, like dual sex therapy, CBT, other behavioral management strategies, mindfulness, which is very useful treatment strategy in general for handling several sexual dysfunction, improving communication relationship status. So these are the common treatment strategies that are useful for handling sexual dysfunctions. We also need to take into consideration that not only serotonergic medications or antidepressants are having effect on sexual dysfunction. Some of other medications like benzodiazepine, which we are very commonly using in depression, may have impact on sexual dysfunction. So we need to handle their doses and time of use also accordingly. Mood stabilizers, anti-epileptic drugs like carbamazepine, phenytoin, phenobarbital, they reduces desire specifically by reducing a freely available testosterone level. There is lesser risk with oxcarbazepine. Valproate can also influence libido and orgasm potential. And lithium in long-term use can reduce sexual desire and may be implicated in erectile dysfunction. So other molecule can also be implicated in sexual dysfunction. We need to take into that also into consideration while handling the individual person. Thank you very much for a very patient listening. I hope that I have been able to finish in time.
Not on time. Thank you so much, Adarsh. Over to chairpersons for their opening remarks.
Shall I start?
Yes.
Yes.
I think it is very clear that there is a cause and effect relationship between depression and drugs. Neither we can keep quiet without treating, nor we can neglect or overlook the effects what actually they can produce. Ultimately, what Dr. Adarsh Tripathi was emphasizing was the contextual factors are extremely important in this management of depression and sexual problems. What it means is an individual who is single, an individual who is married recently, individual who is young, individual who is old, each of these individuals create a different type of issues. The drugs which are available now, we are at a very nice situation in the sense that hardly any worthwhile drug was available maybe even a decade ago. Now we have so many strategies available, so also the drugs available, which can actually make treatment, plan it in the beginning itself that the side effects can be prevented and the quality of life issues can be handled in the beginning only. Of course, the third point what he was emphasizing was the relationship and other related matters. Those who are having in fact, something smooth going relationship, there is hardly any problem. But certain other related things get into the picture. The third point was mentioned was actually the mood stabilizers and other treatment strategies in treatment of depression are maybe associated bipolar, cyclothymic, and such other related factors. The fourth major component is actually sometimes these people have associated diabetes, mellitus, hypertension, antihypertensives, and other related drugs. That means ultimately it is a cocktail of so many things. When we have seen some of the people's prescriptions, we might have written as psychiatrist 1 or 2 drugs. But these are all the people who come with prescription which contains about 10, 20 different drugs, because 1 or 2 drugs for diabetes, 1 or 2 drugs for hypertension, 1 or 2 drugs for coronary artery and other related problems. And in addition to some, say for something for sedation, something for something else actually. So it is a cocktail which many people would be carrying, and that means a lot of such things actually one has to keep in mind. I think I'll stop here because we'll try to look into different questions. Once Nina makes some comments, following that, we'll try to look into the questions. Nina?
Yeah. So it was a wonderful presentation by Dr. Adarsh as always, and very lucid and very take-home clinical practical points. Number of drugs and management strategies for the treatment emergent sexual dysfunctions. Yes, we have read many articles. We try a number of drugs. But as I always believe, we should first ask the question that, are you having sexual issues? What are the sexual issues? Lack of sexual desire, I often find a big, big problem, even if it is a sexual, it is a treatment emergent sexual dysfunction. So the sexual desire, lack of sexual desire becomes difficult to treat otherwise too. Anorgasmia, delayed ejaculation, yes, you can change some of the medications and try to, use a side effect of one to improve the sexual dysfunction. We do all those kind of strategies. But as Dr. Rao has been saying since the beginning, and as Dr. Adarsh put it, that intense or deep or, delving into the history and looking at all contextual factors, comorbidities, all the other medications which Dr. Rao said, none of us actually bother about, okay, will the antidepressant be affecting his sexual dysfunction? We are so focused on the antidepressant causing the sexual dysfunction, or maybe the depression itself being the cause of the sexual dysfunction or the effect of the same, that we often forget the other medications. And changing so many drugs or trying to find a balance between the whole thing becomes quite taxing, not only for the clinician, but also for the patient. And as Dr. Adarsh said, sometimes, when you ask the patient, they say, okay, I don't want to, disrupt this part of my life, which is now stabilized and maintained. Let me see if I can handle this. वैसे भी sex तो कम ही होता है, या I do it that way. Though it should not happen like that, because it is a very important aspect of life which should be fulfilled. So that is when sometimes those non-pharmacological techniques or non-pharmacological therapy actually helps. So I think all in all, yes, a wonderful presentation, Dr. Adarsh, and I'm sure everybody has. I think there were some questions in the beginning, Dr. Alim and Dr. Amrit, about scales being translated in Hindi. So maybe we could take those then.
There are, of course, there is one Dr. Lachand Sunda. In fact, he's asking, the topic is treatment emergent sexual disorders, not other causes, I hope, like that. In fact, I think an academician will always look at any problem comprehensively, and that's what actually the doing justice means. That's what I request Dr. Adarsh to remark on that.
Thank you, sir. What remark? That is setting the context of presentation, as we can understand. Because even if we are handling treatment emergent sexual dysfunction, we cannot ignore other contributing factors. Because we can understand that not every patient is reporting sexual dysfunction with antidepressants. So this is not only the medication. There are some other vulnerability factor, constitutional factor, relationship related factor that might be present in that person, which need assessment and handling in that particular case. So even if we have prescribed a medication and person is reporting sexual dysfunction, we should not think that it can only be caused by our medication. There can be some other contributing factor. We must keep that perspective. That will be helpful in handling that particular case.
This may be little out of context, but all said and done, in fact, anything sexual in any individual have some direct or indirect implications. Is there any medicines specifically addressing the problem of vaginismus? When we are talking about antidepressants, of course, this is one of the important area. And somehow, when we are talking about sex, man gets precedence or preference. So that way, I think a lot of emphasis on that. Adarsh?
Sir, as we know that every disorder, management of every disorder have a lot of strategies to handle. So if I have to give one word answer, is there medication for management of vaginismus? I will say no. But obviously in that particular kind of case, if there are certain other comorbidities, or there are certain other kind of clinical situations that mandate use of additional medication for certain other factors, then we obviously use medications for vaginismus. But obviously there is no treatment of choice in terms of pharmacology for vaginismus. It is more of psychological treatment of that condition.
I'll just add. See, any of the antidepressants or drugs which can actually relax an individual will have a beneficial effect. Just like as we say in case of premature ejaculation in case of men, vaginismus is another area where the primary anxiety as one of the important documentary this thing. So we have to control anxiety. So from that particular angle, this can be one of the very good adjuvant. Any of the antidepressants, more specifically those which actually bring about significant relaxation, have a beneficial effect. I fully agree with Dr. Adarsh that, of course, the primary line of management is actually non-pharmacological in case of vaginismus. There is one more question. Couple sexual history was once or twice a month intercourse before marriage, and post-marriage got declined to once a month. Now post-ID, with 2 years, couple is unable to get back. Total feel causes anxiety. How to go about? I'll read it once more. Couple sexual history was once or twice a month intercourse before marriage. Post-marriage got it declined to once a month. Now post-ID. That means ID means what is the meaning? I don't know.
Child.
Huh?
Must be post child or something must be. Post-age.
With 2 years, couple is unable to get back. They are finding it difficult to use the tadalafil because the individual feels anxious about it.
Sir, I would say that this is sort of non-specific. I am not able to understand the context completely. And management of sexual dysfunction requires understanding of contextual factor, what are the psychological factor, what are the medical conditions associated with that cause. This reduction of frequency of sexual intercourse after marriage has been sort of issue that is very said very commonly, but it is not. It is depending upon the couple's condition. So I think that in this case, only medication is not going to be useful. We need to see that what are the context related factors that are causing this illness. So rather than just prescribing medication, we need to see that what are the issues that we can improve, how can we improve the relationship status, how we can improve the communication, how we can improve the activities that encourages sexual functioning rather than just prescribing medication for handling erectile dysfunction in this particular case, because there is no mention of erectile dysfunction also. There is mention of only reduction in sexual frequency. That might not have any relationship with erectile dysfunction per se.
Dr. Neena wants to make some comments on that.
No, so I agree with Dr. Adarsh, because couple dynamics would need to be looked into. And it's written like couple sexual history. Was it with the same person or with somebody else? Because it was prior to marriage, was once or twice a month. So all those details, post-marriage, it got declined. Post-child, again, it got declined. But nothing is clear until we are clear, until people open up and give all details. Very difficult to set an individualized plan or a couple plan into place.
We have to do
Of course, jokingly to put it, marriage is the single most well-known barrier for sex in many couples, and arrival of the children complicates the whole picture. This is a very natural occurring, and of course, need to look into many other dynamics that are involved actually in that process. Of course, next question.
Sir, it might be a joke, but I do not agree to this.
But in this particular case, premarital and marital, both the issues are there. And once, many of the times, once men actually won the partner, and then actually nothing really to fight for, it becomes like that. Dr. Sir, you want to ask some, want to make some comment?
Tufan sir is talking to somebody.
No, sir, no.
I wanted to ask one question to Adarsh, if I'm allowed, sir.
Yes.
Please.
Others, have you ever seen, patient becoming hypersexual after treatment with antidepressants? I'm not talking about a switch per se in terms of a manic switch with antidepressant. But have you seen cases of people becoming hypersexual with any medication, antidepressants? Other
See-
side of the
See,
spectrum.
it has been reported with primarily dopaminergic medications, and I have seen few cases where I have augmented the patient with pramipexole or ropinirole. I have not even seen with bupropion. In those cases, this hypersexuality, if you reduce the dopaminergic molecule, the hypersexuality goes away. But other than those situations, I'm not able to remember that if I'm using primary antidepressant, the person is reporting hypersexual behavior. Most of the cases when the person come with hypersexual behavior, and if we are able to rule out other endocrinological or other brain related causes, SSRIs are often the first line of management for those situations.
There is
With
one.
vortioxetine, we have not seen. Vortioxetine.
Sir,
I have seen 2 cases with vortioxetine. That's what I was asking you.
No, thank you very much for this information. I am using vortioxetine quite commonly nowadays, and in the last
Personal use or with patients?
Obviously, I'm fortunately hale and hearty as of now. So with the patient. Obviously, I'm using a lot of it, and till now have not seen any such situation. But
Thank you.
I'll interject 1 minute.
yes, sir.
See, it is one is actually depression, and we are treating the individual with antidepressants. See, this is also documented that depression or as individual starts aging, this is what actually called not yet 40. Because of the declining sexual libido, many people become adventurous and try to do a lot of things to prove certain points. Though it is a psychosocial related phenomenon, at least in case of men, this has been documented, and this is one of the reasons why somewhere around 40s, 50s, the extramarital affairs and many other things get into the picture, mainly because of this, because they are trying to prove certain points. With the specific drugs itself, of course, anything which can increase actually, of course, dopamine, this thing, that is one. Sometimes with the corticosteroids, there is a sudden jump in significant sexual activity has been documented in one or few reports. What it means is, in fact, secondary mania it can induce, that is also there. But also, say for example, endogenous corticosteroids act quite differently from exogenous corticosteroids. So apart from dopamine-related drugs, this is one more other one, actually we have to keep it in mind. And any of these anti-Parkinsonian drugs are immensely capable of producing problems. This is also.
Yeah, others. Sir, can I?
Yes,
There
sir.
are some more questions are there.
Yeah, Alokik has asked 3 very important questions. Use of PDE5 inhibitors in TESD in females. So your comments on this?
Yes. So use of PD5 inhibitors in female is a sort of tricky strategy. The evidence base for this strategy is not very strong. And my personal use also does not produce much sort of beneficial effect in the female. So I have tried to use this strategy in females, but I have not been able to find much effect. So I try to use other strategies now. But I will again reiterate that evidence base for this strategy that PD5 inhibitors has been said to be used for improving orgasmic functioning, improving arousal level, for sexual dysfunction per se and TSD, both situations. So evidence base is sort of flimsy and not very useful. I will also invite comment from our chairpersons who might be doing this thing. But in my personal opinion, I have not found this strategy very useful in females.
Literature, yes, ma'am.
Amrit wanted to tell something.
Literature talks about local application and its use in females. Improving orgasm and sexual functioning.
Testosterone implants also over the umbilicus. But most of them availability in India, I am a little doubtful.
Yeah.
I have not used testosterone implants or the patches. Sorry, not implants, patches.
Ma'am, right now we are talking about PD5
Talking about
inhibitor.
PD5.
PDF.
So,
PD5, madam.
what Dr. Amrat is saying, I have seen
Yes.
one female physician in Lucknow who is using PD5 inhibitors as local agent.
Local agent.
She says that take sildenafil 25 milligram and put in intravaginally. But as of now, I have not seen any sort of person who is reporting benefit. All those failed patients come to me back then. So
But literature
maybe
talks about,
maybe
you know,
people who are not
local
responding to that
application.
treatment. So sir, how
When initially we were doing this sildenafil trial,
yes, sir.
we had, of course, this is an anecdotal, this thing what I'm talking here. A person coming and telling that he gave this particular tablet to the wife and she got very excited and actually she demanded sex and things like that. In fact, in this particular fashion, occasional reports actually what we get from the clients is there, but what really made this particular change, we really don't know. See, for example, even PD5 inhibitor, we say half-life is 4 hours, but actually it actually quite effective even pretty length of time, even 10 hours, 12 hours later, not because of anything, but because it improves the confidence of the individual. And that means there are a lot of issues involved in all of these type of things. So that is one actually point. The second one, PD5 inhibitors as primary line of treatment in case of females has not been there in work, and FDA doesn't approve this particular molecule for this particular usage. Alim jumped one question. Actually, there is another one person actually asking.
Yeah, two more
It's a
questions.
good idea to educate the clients about the possible sexual side effects while the medicines are prescribed for the first time. This is what actually the whole emphasis on this program. To emphasize the point again, others, you want to make another comment on that?
No, sir, I agree what you say.
Use of low dose aripiprazole.
Yes.
In
So aripiprazole is useful for handling certain treatment emergent sexual dysfunction due to antipsychotic. It per se does not have any utility in treatment emergent side effects of antidepressants. It can be used for people who are using antipsychotic in certain number of cases with certain precautions and certain like handling treatment emergent side effect of psychosis and per se is a very is another sort of lecture per se. This is a
Would you invite you again?
this is a strategy mentioned there, but it has some caveats, so that need to be understood.
Pragmatic strategies for TSD in patients with OCD as drugs other than SSRIs are not very useful.
Yes, sir. Yes, sir. This is really very tricky and some most of the time very difficult situation because SSRI are the primary mode of treatment there, and second we are using very high doses of SSRIs. So both this situation causes relatively higher prevalence of sexual treatment emergent sexual dysfunction in OCD. But the all other strategies, as we discussed, that addition of other reducing the if the there see again what we are saying, that nuanced approach. First, that you will be encouraging the person to wait for more time, despite you know that this wait is not going to be useful for the person. But I would often say that it is better not to be in very much hurry in handling sexual side effect, because in many cases it destabilizes management of psychiatric status. So we'll use these 3 sentences, wait, which is written in Stephen and Stahl management of any side effect. So we need to psychoeducate, reassure that these are things that can be handled, but please allow sufficient time to understand and see how things goes. Then second level strategies, you can think of adding on bupropion, mirtazapine, cyprohepatidine based on the side effect tolerability profile of that particular individual. addition of PD5 inhibitor can be done for the male who is reporting sexual erectile dysfunction due to SSRIs there. So these are the strategies that can be used in OCD for handling TESD.
Management strategies for antipsychotic induced sexual dysfunctions. Though it will this thing, but in depression too, we use these drugs. Okay, Adarsh.
I think, sir, this is out of today's topic.
Of course.
Out of syllabus.
So we'll take it up another time, sir.
Yeah. And regarding the OCD, I think vilazodone is one option. Adarsh was talking about, but my experience of in patients with vilazodone is quite good. I've started using it. Very less side effects, almost negligible, and good response in depression. And I think one or two patients in OCD, they are also responding to vilazodone.
Nice to know, sir.
There is one question on PDF inhibitors and the headache, what it can cause and how actually to manage.
Yes, sir. So headache is a common side effect of PD5 inhibitor. Specifically, sildenafil is more likely to cause headache. The common strategies to handle headache is that use the less amount of doses as much as possible. A lot of time it has been seen that continuous uses of PD5 inhibitor reduces the frequency of headache. So we need to tell the person that for initial 6 to 10 uses, this headache might be there. It is although troublesome, but not a very serious side effect. You get used to it. And if the headache is persistent and severe, you can use paracetamol tablet for managing headache. That can be done. Or changing PD5 inhibitor, specifically person is reporting more on sildenafil, changing it to tadalafil, changing it to some other PD5 inhibitor, some time can be useful. But what I have used in my, I see in my clinical experience, if you reassure person with full conviction that this is not a serious side effect, it is not bothersome, it is not going to make things very serious, it will go away after you use several doses as is recommended. Patients are able to tolerate those medication, and usually after 6 to 8, 10 uses, the frequency of headache reduces and it goes away.
Alim, shall I ask the question again?
Sure, sir. Sure.
What is your experience of aphrodisiacs food in such treatment emergent sexual side effects, like say oysters? Any comment?
Sir, aphrodisiac per se are not, they are not very evidence-based treatment strategies. I would not say that we can convincingly say with any such strategy that whether this has been useful or not. But these are the common strategies that are suggested to patients that in addition to other kind of medications, the strategies you use this sort of strategies. So best aphrodisiac is interested and interesting partner, as Dr. Rao sir say. So try to make spice up your relationship and improve relationship quotient, and try different kind of strategies to increase interest and interesting quotient of your partner. Then there are a good amount of food that are reported to have some aphrodisiac property. Obviously, in addition to all other strategies you can suggest, but you can never be fully sure that whether those strategies are useful in this particular case.
Of course, one of the very interesting question actually is there next, and I think everybody has to make it aware. Women often are reluctant to complain of sexual dysfunction, and even we are uncomfortable asking, are there any idioms of distress like symptoms as to what kind of complaint should make us suspect sexual dysfunction? Very good.
Actually, this question is really very good, and there are a lot of cultural context and conditional context. So first thing that I would like to say that this is not always the case that women are very reluctant to talk about sexual things. Situation vary. Like in several cases, female are very easily forthcoming about their sexual problem, and they are able to talk very easily and comfortably. In the certain cases, if where specifically in situation where there is significant age difference, there significant socioeconomic education, socioeconomic level difference, significant educational level differences, gender discrepancy, these are conditions and contexts where people might have some discomfort in talking about sexual dysfunction, specifically women. This term idiom of distress, so people have suggested using a lot of different terminologies for handling or asking sexual dysfunction, like जैसे कि हम लोग, if in Hindi speaking belt we often talk about कि क्या आपको अपने मतलब पति के साथ पर्सनल रिश्तों में कोई समस्या हो रही है, आपके व्यक्तिगत जीवन में संबंधों में कोई प्रॉब्लम आ रही है, आपसी जो पति के साथ जो संबंध है, इस तरह के यूजुअली टर्म्स हम लोग यूज करते हैं। मेरी वाइफ गायनेकोलॉजिस्ट है, तो वो कहती है कि हम लोग पूछते हैं कि पति के साथ बातचीत तुम्हारी ठीक होती है, एंड मोस्ट ऑफ द टाइम शी सेज दैट पीपल आर एबल टू अंडरस्टैंड, बट इन माय psychiatric practice I often fail to reproduce this practice because patients do not understand कि बातचीत जो है पति के साथ ठीक होती है. So this idiom of distress might be regional and dependent upon what is the educational and socioeconomic background of your person. So in that way, one understand.
In fact, in one of the papers we have mentioned about what all the ways actually a woman, in fact, presenting and suspect sexual this thing. In fact, these are all very common psychiatric problems only, but all said and done, emphasis on that. What it means is a woman present with multiple somatic complaints, not responding to any specific treatment, requesting for various investigative procedures, more particularly the invasive procedures, person who emphasizes emotional problems, a person who de-emphasizes emotional problems, who actually repeatedly wants certain consultations. So, important point is actually we have to be almost always suspicious, just like in case of men. The issue has to, that means the inquiry has to come from the doctor. Do you have any sexual concerns to discuss with us? That's what actually Adarsh mentioned. One of the very, very important, you have to break the ice. And in case of women, I fully agree with Adarsh because at least quite a few studies we have done as far as the women population is concerned. They are very forthcoming, and many men come for consultation only because of the women. That is one aspect of it. Many men fail to bring women to the consultation not because of anything, because of their own anxiety. The third one, they say that they are not informed wife, but wife will be the first person to know what actually the problem is happening. So the nuances or issues involved are quite a few, and very important that the female sexuality deserves significant attention. And of course, we are very lucky that a woman psychiatrist taking up this particular job in a very big way. Neena Sawant is leading that from the front. And I think, any comment, madam?
No, so I agree with you totally. Things are changing, and women are definitely, yes, talking and coming about it. Like you've said, somatic complaints, like we have a rule, no? So just psychiatric symptoms exist in each and every patient unless found out. I always believe sexual symptoms are present in each and every patient until you ask. So it should be asked, and then yes, you unearth a lot of symptoms. That should be your motto.
Of course, I see sex everywhere, and I always say, every person you meet on this earth, there were sexual problem cases yesterday, today, or tomorrow. You got the point? Keep it in mind and ask everybody at least one question. Do you have any sexual questions to ask? There is one Mayo Clinic 4-question scale. What it means is, do you have any sexual problems to discuss? That is one. Do you have any relationship, other related issues with men and women? Of course, the third question. Fourth one, currently do you have any problems to talk about or concerns to discuss? That means, of course, 4 questions almost related way, but one simple thing, what in fact Adarsh mentioned in his presentation also. One simple question, do you have any sexual concerns to discuss, opens up the floodgates, and both men and women, this rule applies. I think we should follow that. There are a few more questions related to antipsychotics and other related disorders. Depends on the coordinators of the program, whether to ask those questions or not. Thank you. In fact, personally, I'm really obliged to organize for this wonderful opportunity, what you have provided for me, for co-chairperson, and of course, others from my side.
Thank you. So Legendary has shown increased sex drive. Any comments on this?
Sir, yes, as we have discussed that lot of several medications that influence dopaminergic function in the brain do have potential to alter sexual functioning. Increasing sexual drive is one of the most common effects that has been reported. Our management of those medications for improving sexual dysfunction has been a debatable issue. In the same way, salicylic per se has not been, in my knowledge, it has not been significantly studied and utilized in that way. Some of the strategies which we have not mentioned in my presentation, like some of the strategies using dopaminergic add-on for management of sexual dysfunction has been reported, like pramipexole or ropinirole can be used for improving desire-related problems that are caused by treatment-emergent sexual dysfunction. However, evidence base for those strategies is very limited, and we need to see in case-to-case basis that whether they are useful without causing significant additional side effects.
Okay, is there anything like permanent ED after medications? After medication?
Sir, as I have reported that there are literature reports saying that post-SSRI sexual dysfunction is an entity where even after stoppage of treatment, the sexual dysfunction continues indefinitely, very long. However, there are significant doubt on presence of this entity, and most of the research data says that after stoppage of antidepressant for several weeks, sexual dysfunction reverses in most of the cases.
Any role of
Sorry?
Any role of oxytocin spray?
Oxytocin is very personally, I don't have any experience for use of oxytocin in management of sexual dysfunction, but theoretically, oxytocin is finding use in sexual dysfunction per se. So it might be useful in treatment emergent sexual dysfunction also. It is being promoted as one of the treatment strategy for women sexual dysfunction. But I obviously do not have any experience, and my reading has been limited to this only.
And also a question on use of L-arginine gel locally for female sexual dysfunction.
So this is also a reported clinical strategy for management of sexual dysfunction, but I'm not very sure of its utility or efficacy in management of this situation. I have personally never used. I've used it orally with very limited success in female sexual dysfunction. In male sexual dysfunction, it does have some efficacy of sexual dysfunction, which is not caused by any antidepressant. In sexual dysfunction, which are treatment emergent, I use a strategy which are mentioned in this presentation.
For example, regarding arginine, only one small comment. See, as far as the men, in fact, we published one detailed review related to arginine in Journal of Psychosexual Health, and I can post it. Important point is that particular strategy has not been found to be very useful compared to, say, use of PDE5 inhibitors and things like that. All said and done, many of the studies which are there, which indicate that anywhere between 6 milligrams and above, only this is effective. Less than 6 milligram, it is not. The third one, there are a whole lot of phytochemicals which actually release arginine, and they are beneficial. One of the, in fact, I'm immediately not getting the name of the chemical, but trade name is Prilox. which actually, in fact, acts on arginine mechanism and actually subsequently it benefits, has been found to be useful both in case of men and women, and quite a bit of data available on that particular point. But none of these studies are done in Indian context, and we have a very limited idea related to that point. So arginine, we know, physiologically speaking, it is one of the important source for nitric oxide. But as such, how it actually works and in whom it works and what are the other contextual factors and gender-related issues related to this, there's a whole lot of questions still there. Thank you.
Thank you, sir. I think we have covered all the questions in the chat box. So comments from chairpersons, final comments, and then we move to Tufan, sir.
Ladies first.
I think we've had a total discussion which has spanned 1.5 hours. I think it was a wonderful session. Thank you so much, Dr. Adarsh.
Thank you very much.
Personally, and in fact, because of our colleagues also, in fact, we are really grateful for this wonderful opportunity. And the treatment emergent sexual dysfunctions is one of the very important area from psychiatrist's perspective. In fact, day in, day out, this is one of the problems. Just I'll tell you one small example. In our Department of Psychiatry, patients take medication, and then ultimately they come because they want to discuss something. And what is that particular something is, I'm taking this medication, whether something need to be done related to some problem. What it means is, every psychiatrist has to take some time, make inquiry, help them, and this is the message. I think from that particular angle, this Thursday Musings is doing a great job, and this is one of the very topical, very important area, and day in, day out, bread and butter issue related to psychiatrists. Thank you very, very much.
Thank you, sir. Tufan, sir. So please unmute.
Thank you very much. I was out of my place. I was in Delhi for the NAV meeting of IAPP. When this meeting started, I was in the aircraft. But considering the importance of the topic and considering other stuff and the stalwarts behind, I joined in from the aircraft in the beginning. I was still in the aircraft. And as soon as possible, but I was listening to everything. As soon as I could afford to have a laptop connected, I joined. Now I have not started for my home also. So there are many questions, but most of the questions are discussed, and we will be having other one thing, others. What about the treatment emergent sexual problems in LGBTQ? Or it can be a complex issue.
Sir, largely the LGBTQ people also experience a similar side effect profile, which we discussed, because in my understanding, the sexual relational or the way disorder are specific are not very significantly different. The way they relate, the way they perform sexual activities, the way they express their sexuality, that may be different, but the sexual dysfunction per se are similar in LGBT versus heterosexual couples. So the assessment approaches and handling largely remains similar to what we have discussed today. That is what my understanding is. Maybe chairpersons can put some additional light on this.
Dr. Rao, sir?
Well, of course, I think the point was made very clear. We human beings automatically, that doesn't make a difference. That is one of the reasons why this particular third gender and other related issues have been knocked off from being pathological states. The issue is if somebody is having erectile dysfunction, that need to be treated. If a woman is having certain issues related to the libido and other related things, that need to be treated. And all same physiological issues. If we try to look at both men and women, some things are extremely common in both. See, for example, orgasm, 0.08 seconds. Both in case of men and in case of women, it is same. But to reach that particular point, woman takes a very long route and the man takes a very short route. That's all the point. That means there are some barriers and other related things which are there, one has to overcome. But as far as the LGBTQ issues are concerned, still we are at a stage where very confidently won't be able to answer. But practically, it looks like what is actually applicable to others and equally applicable to this particular group.
The basis of my questioning was that these issues have a socio-cultural backdrop. Be it treatment emergent, be it sexual problem per se, does not matter. Today also we have to debate and try for their rights, even today. So that means, in general, the society as a whole is yet to accept it, although we psychiatrists over here tell it is okay. So that will have a effect on their well-being, especially psychosocial and sexual well-being, quite natural. And what we or a couple expect, heterosexual couple, the demand expect out of the sexual interaction can vary in them also, and their problem could be different just because of being Homo sapiens. We should not stop at thinking that there is no difference. There may be difference, and our approaches should be different. That is what I wanted to highlight. And you are the big boss.
And the point is well taken, sir. I think a lot of research that need to be done and the data need to be generated, and more particularly the Indian context.
Yeah, thank you, sir.
Thank you very much, others. It's nice. You have been speaking about this topic, always smiling from the beginning till now. I think this topic also pleases you. Thank you very much. And thank you, Dr. Ninas. And thank you, my dear friend, Dr. Rao. Thanks, Adim and Amit. I feel privileged to reach in time, although at times flights run late. Thank you very much. Over to Amrit.
Good night. Thank you.
Amrit, formal.
Formal thank you from the IPS Odisha State Bench. Others, thank you so much. You're very, very simple, clear, and it didn't make it very complicated. So it was as if it was a conversation which was going on around, taking care of all the points, not complicated, because sometimes, most of the time, I feel sex is in the mind. Even the side effects are in the mind. Even the treatment for those are all in the mind. So you made it very clear. You made it very clear. Thank you so much, Rao sir and Neena madam, for clarifying all the doubts, adding all the inputs. Thank you, Alim. Dr. Tofan sir, we are extremely indebted to you that you could join. And from the flight also, that shows your dedication, devotion, and your special interest towards this topic. So thank you. We've had more than 200 logins, around 250 logins. Speak of 200, that's great. That's actually a great thing. Thank you, IPS Odisha State Bench, our followers, and Torrent for this whole making it a huge success. Others will see you again.
Thank you.
Because the antipsychotic part is remaining. And Alim is telling if you can share your PowerPoint with him. Thank you so much. Good night.
Thank you so much.
Thank you. Thank you so much, everyone. Good night. Good night.
Thank you, everyone.
Yeah.
Okay, good night.
Good night.
Thank you. Thank you, sir.
Good night.
Thanks,
Thank you.
everybody.
Thank you so much.
Good night.